Hello everybody, welcome on this webinar. I'm Stephen de Koning, I'm your host for today. I'm the chairman of the European Teaching Group of Orthopaedic Medicine, and together with my international teaching team, we offer continuing education projects in musculoskeletal medicine all over the world. Just check out the website cyriax.eu to find out more about the different cities in which we offer those courses. This webinar is broadcasted live from the Edgom Training Center here in De Haan along the beautiful Belgian coast. This is the place to be. This is the place where we offer the mastermind training on orthopedic medicine, a very special private training, 7 days intensive training for maximum 4 participants. Check out the website and find out all the details about this specific training. But before we go to the actual webinar, the topic from today, I would like to invite you to join our scientific Facebook group, OMC Modern Orthopedic Medicine Network. On this Facebook group we focus on interesting scientific information, some interesting discussions. Please join the group and get inspired. And for those of you who didn't download yet the free ebook on clinical reasoning, 156 pages practical information on clinical reasoning, diagnosis and differential diagnosis, well, do it today. Yeah, surf to cyriax.eu and get your free ebook today. If you want some more information, where there are different ways where you can find information about orthopedic medicine, the main website cyriax.eu, there you find everything you need to know about the international program. On learnorthopedicmedicine.com you find everything you need to know about online training, how you can study at your own home. Cyriaxcourses.com, there you find everything you need to know about the mastermind private training and the special Reboost course. And of course we have some more partner websites, Spanish information for Latin America, information for Southeast Asia, information specifically in Chinese for Taiwan and China, for the Polish area and also for the Slovenian area. So let's move on to the topic of today's webinar. Well, today's webinar is going to be presented in a nice film where you're going to get some specific inspiration on today's topic. So enjoy and see you later. Let's talk a bit about tennis and golfer elbow. Tennis elbow, of course, is a very frequent lesion. It could be also a very annoying lesion, could also be very acute. What's a little bit the background of it? Well, in many cases it's kind of an overuse phenomenon. It is a repetitive strain injury. People who are constantly involved with extension activities of the wrist, cleaning ladies, working a lot with a desktop computer but in a non-ergonomical position, people who work in a factory and have to do repetitive movements all the time. So this is a basic element. Sometimes it's post-traumatic, but that's not so frequent. But we see many so-called chronic tennis elbows. It started one day and they didn't get any real active treatment that influences the scar tissue. So nature is taking care of everything. You have the inflammation phase, you have the repair phase, the remodeling phase, but during the repair and the remodeling phase you get adhesive scar tissue which could play a role in chronic lesions. So when the patient doesn't put too much loading on his elbow, then activities of daily life are more or less okay, but the moment he does some more intense activity, it is not okay. So it's a story of constantly upside down, yeah? Better periods, worse periods, better periods. Chronic lesions are difficult ones to treat. But a tennis elbow very often has a very typical story. So one element you already heard, In the story, you have a lot of repetitive extension activity. And they say they have pain over here, most likely with some radiation in that direction. In acute cases, there's certainly radiation, sometimes radiation until the middle three fingers. Yeah. And any activity involving extension is very annoying. Yeah. When they pour out the coffee in the morning, for instance, painful. Yeah, sometimes they just drop things. When a patient comes in and you say hello to the patient, hi, what can I do for you? How are you? Yeah, just by shaking hands, and he says, it hurts. You're practically sure he has a tennis elbow type 2. So it's really very obvious. And what do you find in the examination? Well, your resisted extension from the basic examination, of course, quite painful. With acute lesions, you're going to have pain and weakness, but not weakness because there is some rupture or so. No, if you ask for a full contraction, it's going to look like this. Pain and weakness because it hurts too much. Yeah? As an extra test, fist movement, again extension, again quite painful. And sometimes the radial deviation against resistance is also painful. Yeah? And then the question, of course, is, are we talking about extensor carpi radialis longus and or brevis? Well, in literature they describe an extra test for the brevis. You could do a resisted extension of the middle finger. That could be positive, but it's not 100% reliable. So the more reliable way to make a differentiation between longus and brevis is going to be palpation. Yeah? So, as I mentioned earlier, repetitive strain injury is an element that plays a role, as well as adhesive scar tissue. And we may not underestimate also the role of degeneration and some relative avascularity. So, I think that a combination of those elements plays the biggest role in a tennis elbow. But then the major question, what are we going to do with it? Well, in the Cyriax approach, we're going to do deep transverse friction massage. Sometimes we combine it with a Mills manipulation, but that's not 100% guarantee for success. No, we have to be honest. There are tennis elbows which don't react 100% on the strategy of friction manipulation and stretching. The only problem is we never know that in advance. It would be very nice to know that in advance, but unfortunately we don't. Stretching techniques, shockwave could also be an alternative. Infiltration. One little detail about infiltration, it should be on the correct spot. And there's only one type which is infiltrated, this is type 2. In total we have 4 or 5 different types, so infiltration is exclusively for type 2. Perhaps surgery, perhaps some other options. There's also a mechanism of spontaneous evolution, so if we don't give any treatment, more or less in about 1 year time, it recuperates reasonably. But of course, we're not going to wait 1 year. When the patient got an infiltration with corticosteroid, the spontaneous evolution does not work anymore. Well, 4 different types. In some books you find 5 types, so if you want, I can also give you 5, that's no problem. Type number 1 is the origin of the extensor carpi radialis longus. Type number 2, the most painful one, the most acute one, the most annoying one, is extensor carpi radialis brevis, the origin. Type 3 is the tendinous body of the brevis, and here you can make a distinction, 3A and 3B if you want. There could be a lesion at the height of the joint line, but there could also be a lesion at the height of the radial head. And then type 4 finally is the muscle belly. So as I told you, type 2, let's say in 90% of the cases we talk about type 2. But it happens sometimes that you have a combination of types. Patient has type 1 and 2 at the same time, or 2 and 3 at the same time. Well, that's just more work for you. Well, it's again very important that we manage our palpations in a good way, that we really have a good specific palpation. This is the palpation for type 1. The important thing is we have to be on the anterior border of the humerus. Yeah? Type 2, very important over here for a type 2, is you really have to flex your thumb, and we palpate and we friction with the tip of our thumb on the anterior aspect of the lateral epicondyle. Always use a layer of cotton wool, because otherwise you're going to damage the skin. This is really a very tiring technique. Not for the patient, but for the therapist. Yeah? Not to be underestimated. Type 3, we're going to change the position of the patient. So for type 1 and 2, the position of the arm was 90 degrees. For type 3, we're going to 3/4 of extension and pronation. And then with a flat position thumb, we're going to take a contact on the tendon at the height of the radial head or at the joint line. And then finally, type 4, we're going to squeeze the muscle belly. And then exclusively for type 2, we're going to perform a Mills manipulation. Well, in fact, if you summarize the treatment strategy for a type 2, we're going to do 15 minutes of deep friction type 2, followed by 1 manipulation. We do that 2-3 times a week, and you need an average of 12 to 15 sessions. Don't give up too soon. It happens really often that the first 7 or 8 treatments, it's not that better, and the patient is losing his courage. And then treatment number 8, the patient is coming in with a big smile, and he says, since your last treatment, now I start to feel a difference. Now it's better. So don't give up too soon. Average of 12 to 15 treatments, maximal 3 times a week. And in between, at home, the patient also has to do some stretch exercise. This Mills manipulation is not that easy. It's a nice test for the rhythm in your blood, so to speak. Actually, it has not been developed by Cyriax, that's logical. It has been developed by Mr. Mills already in 1928, but Cyriax in due time made some modifications. And what is the purpose? What is the purpose of this Mills manipulation? Well, elongate adhesions interfering with the mobility of the tendon and so on. A golfer elbow is far less frequent than a tennis elbow, and it's also less invalidating and most likely also less acute. The patient describes some pain over here, sometimes some radiation, but not too much. Mostly it's local pain. And in the story again, you hear the key factor in the story is a kind of repetitive strain injury or occasionally a trauma. Well, what you find in your examination, your resisted wrist flexion, of course, is painful. Yeah. But it is possible that your resisted pronation is also painful. And what is the reason for that? The pronator teres lies over there, partially originates from the common flexor origin. So, if there is a problem with the flexor origin and you do an intensive pronation, some tension could be referred and the patient says, ow. We have 2 types. We have a tenoperiosteal type, which you can infiltrate or you do deep friction, and we have the musculotendinous junction type. Keep in mind, musculotendinous junction is always friction massage. It's never infiltration, okay? The trick to do a good palpation is keep the elbow in full extension. Yeah? And then you have to, for the tenoperiosteal aspect, you really have to palpate on the anterior aspect of the medial epicondyle. You don't have to friction the medial epicondyle, you have to be on the anterior aspect. But if you are a little bit too far in that direction, then of course you're going to friction nervus medianus, and this is not the purpose. That's logical. Well, let's have a look at all those treatment techniques in a live version. So enjoy your discovery. The starting position is 90 degrees elbow flexion and supination. We palpate the lateral aspect of the lateral epicondyle. We put our thumb a little bit higher until we reach the sharp edge just above the lateral epicondyle. We flex the thumb 90 degrees so that the thumbnail now faces forwards. A reserve of skin is given upwards and pressure is applied on the anterior aspect of humerus. The active phase of the deep friction is an arm movement, downwards with pressure in a posterior direction, followed, as always, by a phase of relaxation. The starting position is 3/4 of extension and pronation. We have to check two localizations: the tendon level with the joint line, or level with the radial head. The thumb is put as flat as possible on the lesion. A reserve of skin is taken in a medial direction, pressure is applied, and the active phase of the deep friction is a movement in a lateral direction. Make sure you perform an arm movement instead of an isolated finger movement. The starting position is 90 degrees flexion and supination. Level with the neck of the radius, a pinching grip with all fingers is used. We pinch the muscle belly. The therapist stands at the posterior aspect of the patient, the proximal foot at the height of the patient's shoulder. Always check the range of extension first. 180 degrees is a minimum range required. The patient's shoulder is in medial rotation. 3 elements have to be built in: maximal wrist flexion, the therapist's thumb between thumb and index finger of the patient, maximal elbow extension, and finally a step sideways behind the patient's back in order to increase the tension. These elements have to be coordinated, and the manipulation itself then becomes a combination of these 3 elements. We keep the elbow in complete extension. We find the medial epicondyle and proceed to the front of it. At the tenoperiosteal junction, deep friction is a straight line movement and the feel is rather hard. At the musculotendinous junction, about 1 centimeter more distally, the deep friction is a more ample round movement and the feel is softer. The patient sits with his arm lying on the couch. His elbow is flexed 90 degrees with his forearm in full supination. The therapist applies his thumb to the anterior aspect of the epicondyle, with his fingers on the ulnar side of the elbow, and ascertains the boundaries of the tender spot. The needle is inserted vertically, just medial to the tip of the thumb, until it pierces the tendinous insertion and hits the bone. First, a droplet is injected here. One continues with injecting 20 or so droplets into the area of tenderness, several superficial injections, and several more deeply. The patient sits with his arm lying on the couch. His elbow is flexed 90 degrees with his forearm in mid-rotation. The tender spot in the muscle belly is held pinched between thumb and index finger. The needle is inserted distally to the tender spot and obliquely through the brachioradialis muscle until it hits the radius. It is now slowly withdrawn until it lies between the pinching fingers. The infiltration is given fan-wise and also with some reinsertions more superficially and more deeply until the entire lesion has been infiltrated. The patient sits with his arm lying on the couch. The elbow is in extension and held fully supinated. The therapist places his thumb on the most tender spot, anterior on the medial epicondyle. The needle is inserted vertically until resistance of the tendon is felt. One droplet is injected here. Using the same technique previously described in curing the type 2 tennis elbow, the rest of the solution is injected. So, what do we remember from this film? Well, tennis elbow, mainly 4 types, perhaps 5 types, golfer elbow 2 types, but a solid, good palpation technique is going to be very useful, not only when you think of performing some deep transverse friction massage technique, but also if you would like to do some needling techniques or you would like to apply, for instance, shockwave therapy, then a good diagnosis, a specific type of tennis elbow, specific type of golfer elbow, will enable you to apply your shockwave in a more efficient way and in a more practical way. So that's going to be quite important. So if you have any further questions, if you have any further suggestions, please feel free to use the live chat. And if you're watching this webinar in a replay mode, then just use the email function and just send me an email and I'm going to be happy to reply you. Well, the film you just saw on tennis and golfer elbow is part of the online course in orthopedic medicine, the masterclass in orthopedic medicine. This masterclass contains 68 different films, each film between 5 minutes and 30 minutes, more or less, about 16 hours of film on diagnosis, clinical reasoning, and therapy strategy. Well, if you have more interest in this online course, just surf to learnorthopedicmedicine.com and you can sign in for a monthly fee. And if you use the bonus code webinar, then you're going to get an extra surprise. So remember, if you have any more questions, please feel free to send me an email. It was my pleasure to be your host today, and see you on the next webinar. Bye-bye.